Okay, well, my clock says 2:45, so I think I'll go ahead and get started. Welcome to everyone who is able to make it today. I'm glad that you were able to attend my session. My name is Valerie Connor, and I am a speech therapist at the Quad Cities Rehab Institute, which is a hospital. It's an Encompass Health hospital. We are a standalone acute care rehab facility in Davenport. Sorry, I live in Davenport, in Moline, Illinois. They're across the river from each other. I am also a professor at St. Joseph's College of Maine. I have been a speech therapist for over 20 years, and I've been teaching online for about 15 years. My second master's degree is in health education, and so that's my focus for teaching. I'm going to go ahead and go over the objectives for today, and then we'll dive in. So the goals for this session are to define some common health literacy challenges affecting individuals with communication deficits, and also identify common communication barriers that those individuals experience when consuming health education materials. And then at the end, I'm going to give you an action plan that I hope that you'll be able to take back to your facilities and utilize at least a portion of that. As I hear the bells going off, I do apologize. I was hoping to be at home to give this session, but I couldn't get away soon enough today. So if you hear bells, I'm at the hospital. So I tend to forget about them. So if you hear them, that's where you know where we are. I went ahead and I introduced myself so that we can pass on. All right, so first I just want to give you a little definition of what health literacy is in the acute care setting. Patients that come to the acute care setting generally do so because they've had an emergent need. So they've either had something like a stroke, or they have had a major illness that caused them to be admitted to the hospital. They're deemed not quite ready to go home. They're in need of some rehabilitation, but they're medically complex enough that they still need to be in the hospital. And that's where inpatient rehab, or IRF, comes from. We accept patients based on their medical need as well as their rehab need and their ability to participate in 3 hours of rehab a day. We tend to see a couple different kinds of patients. We see patients that have had just an emergency, but they have a pretty lengthy health history. We also see patients who their first visit in quite some time is because they've had an emergency. So these are patients that are not generally following up with physicians on a regular basis. They don't have necessarily an assigned primary care physician who's doing their lab work and checking things on a yearly basis. And it could be that they have a general distrust of the healthcare system, or they find the healthcare system too expensive. So they either have inadequate or no health insurance. We also see patients that are just generally healthy and they haven't had any problems. And so they didn't really see the need to go see a physician because they weren't having any health problems until they had a major emergency. So those are, I would say, the two categories of patients that we are spending the most of our time providing education to, because when they have their stroke or when they have their major issue, oftentimes it's because of something that hasn't been addressed before, such as diabetes or high cholesterol or high blood pressure. And this is where we are providing a lot of education, and it's really important for the healthcare professionals to educate properly, because if we don't educate them properly, then we're more likely to see readmissions to the hospital. We want them to go home and to follow the prescribed recommendations that we're giving them. So in general, the U.S. healthcare system assumes that all patients have appropriate language literacy skills, and we know that this is not the case. 50% of U.S. citizens have difficulty comprehending health information. Health professionals work in health literacy and terminology and language every day, and we're presenting information to patients every day. And so we are very familiar with that terminology. Unfortunately, our patients, if it's their first time coming to a healthcare professional in many, many years, or if they've just never really gone to a healthcare professional, all of the information that we're presenting to them is possibly something they've never heard of before. And so it's important to remember that. Limited health literacy is linked to patient safety risks. So as I mentioned, if patients are choosing not to follow up with the care that they're receiving, or their prescribed recommendations, then it can be a patient safety risk. So now we're looking at patients who might not really understand the need for certain medications that were prescribed for them. They might not understand the need to follow up with cardiac rehab, or to watch their blood sugar levels. And so these are patient safety risks. It is estimated that $50 to $70 billion are wasted each year due to a lack of understanding of health-related terms. So it can result in things like lengthier hospital stays, more frequent acute care admissions, unused or improperly used prescriptions, and then lack of proper interdisciplinary care. So our goal in the acute care setting is to send patients to their least restrictive environment. So we prefer to send them home if at all possible, or to a long-term care facility if that's where they were residing prior, or if that's the next step in their care level. And we want to try to prevent readmissions, not just because it's something that hospitals strive to do based on CMS regulations, but also because we want patients to go home and be healthy and be safe. So making sure that we provide information in a way that patients can understand improves the overall experience for patients and prevents those hospital readmissions, as well as difficulties down the road. Okay, so let's look a little bit at specific definitions of health literacy. So health literacy is defined as the degree to which individuals have the capacity to obtain, process, and understand basic information and services needed to make appropriate decisions regarding their health. So we know that literacy crosses all comprehensional barriers. So this includes reading, writing, listening, speaking, and conceptual knowledge. So when we think of health literacy, sometimes we think of just the reading of the health information, but we don't always present information to people in the written form. So we have to keep in mind that it also is affected by their ability to listen and comprehend, as well as their ability to speak the information, because to verify that someone understands, we sometimes ask them to reiterate what we said, and we want them to be able to speak the lingo as well as understand the lingo. I recently had a patient not too long ago who had just a mild stroke, not a very severe stroke, and it was causing some memory deficits. And most importantly, what he said was that he had stopped reading for enjoyment because he couldn't remember what he had read. And I think that he had really great awareness of his deficits. And so it was he's very in tune to the fact that I'm reading, but I'm not remembering. So that conceptual knowledge is also important when we're talking about health literacy. Just because you understand it when you read it one time doesn't mean that you're going to retain it. And so all of those things are necessary when we're really looking at true health literacy for patients. It points to the need for, a comprehensive evaluation to understand, not only are they understanding the words that we're saying, but they're able to potentially write them if they need to, that they can hear what we're saying, and that they understand and can remember. So let's look at some common health literacy challenges that occur, especially in the inpatient rehab setting. The first is that of education. So if patients have a lower level of education, then it's known that their health literacy is probably going to be lower as well. It doesn't necessarily coincide 100% of the time. So we do have patients who maybe never finished high school, but they were lifelong learners and they went on and became well-versed in information themselves. And so that is a possibility. But here in the inpatient rehab department, we run into quite a few people of the generation where they went through the 8th grade and then that was the highest level of education that they attained. And so it's important to remember when we're presenting information to them that we are remembering that they have potentially an 8th grade or less reading level. We're also looking at things like language barriers. And so language barriers can come in a variety of different forms. It could be because a preferred language. So we see a lot of patients who have their first language is not English. So it might be a difference in language. It could be because they have a loss of language due to a stroke, such as aphasia. Aphasia is the difficulty in finding words and using words. Aphasia can also be caused by things like frontotemporal dementia. So it can be a stroke or it could be dementia as well. And language barriers also occur because of hearing loss. So as patients have a greater difficulty hearing us, then it can impact their comprehension. Another health literacy challenge that often occurs in the acute care setting would be that of a learning disability. And so we do occasionally have patients that come to us from facilities in our area where people live in group homes. And they just have a learning disability or even developmental disabilities. In those cases, especially if we think they are not going to be able to understand the health information we're presenting, then we would, turn to an advocate to assist them. But other patients have just always struggled with ADD, for example, or they've always struggled with dyslexia. And so we want to make sure that we respect that and provide information in ways that they can best understand. We also run into visual deficits. It could be because they have cataracts or glaucoma. A lot of our patients who have suffered strokes, especially if on the left hemisphere, have what we call left neglect. And left neglect is where the body simply doesn't register anything on the left-hand side, including the visual field. And so as they're looking at the TV, for example, they might only see the right-hand side of it and they don't see the left because the brain just ignores the fact that it's there. So we have to really work with patients to train them to look to the left, don't forget that left-hand side. There are things we can do to help them too, like use highlighters as a guideline, or they make these great Post-it notes that are transparent but colored, and those things are helpful. We also, one other issue that comes about with strokes is patients will have a visual deficit of double vision. And this is really detrimental because it kind of makes them feel queasy and sick, and it also makes it so it's very difficult for them to read because they're seeing things on a different plane, and it's frustrating for them. So then we might have to turn to other forms of literacy. So reading the material to them is often a better option for that. Neurological disorders that we might run into that can affect literacy would be things like patients who have deficits with memory, both short-term and delayed memory. We might have patients with attention difficulties, which is the lack of ability to concentrate and to tune out other distractors. So like as I'm sitting here talking to you, I'm tuning out things that are going on around me. Patients that have deficits in attention have difficulty doing that. So you might be talking to them and trying to explain diabetes to them, but they're listening to a conversation next door and they're not able to tune that out. Another is that of verbal reasoning. So if they are have difficulty with problem solving or putting things together in logical categories and things like that, it's hard for them then to understand what we're saying. Another common challenge is that of cultural differences. And we run into cultural differences across the country in different ways. So you might have certain cultures in your communities And some of them have some different fears when it comes to the health setting. So they might have trust issues, or they might have special preferences. And if we don't really strive to meet those preferences, then that sort of consumes them and also makes them leery to seek out assistance in the health community. So we want to watch out for those cultural differences. And then economic status. So we know that that people that on a different economic status can also kind of coincide with their educational level, not always, but sometimes. And also that economic status can also impact their ability to take that information in if they're really worried about, well, where am I going to go next? So you're trying to tell me how to control my blood sugar, but I need to get back to my job because I have to go to my job or I can't pay the bills. And so understanding and being cooperative with that economic status is really important. So patients with low health literacy have an increased chance of acute care transmission. So that's 15% versus 32%. So we really want to pay attention to how we are working with and treating patients, because we know that if they have low health literacy scores, they are more likely to be admitted to the hospital and more likely to have an acute care stay. We also know that lower levels of education are associated with poorer health outcomes. And it doesn't necessarily have anything to do with their ability to understand the health material or just in general their education. It's just a statistical fact. We know that people that have lower levels of education tend to have poor health outcomes. And so making sure that we spend more time with people that have less levels of education is really important, because we know that they're more likely to have poor health outcomes. So anything that we can do to try to overcome that should be something that all healthcare organizations strive to do. All right, so I am a speech therapist by training, and so that's the gist, or the crux of our presentation today is to talk about basic communication deficits and what we can do to help improve patients' overall health literacy. So first, I just want to spend a little bit of time defining these communication deficits. So you may be familiar with some of them, or you've maybe had family members that have been diagnosed with some of these communication deficits, but I'm going to go over each of them just to make sure that you're familiar with the different types. So the first is that of aphasia. So aphasia is generally most often caused by a stroke, but as I mentioned before, it can be linked to other types of dementia, such as Alzheimer's, vascular dementia, and frontotemporal dementia. There are a variety of different types of aphasia, and in the 20 years that I've worked as a speech therapist, 25 now, I guess, I would say no two aphasics are alike. So generally with aphasia, this is known as word finding problems. So if we have just, general expressive aphasia, patients can think of the words. So the words are all up there, but the connections between their ability to say them and find them are broken. So they know the words because we don't lose the words, they stay in our brains, but they lose the ability to find the word. So as they're speaking in a sentence, they might forget the word, they can't find it, and so they're unable to say it. The worst and probably most difficult type of aphasia is that of global aphasia. So these are patients that are unable to understand what we're saying, and they're also unable to speak. So generally, if you speak to them, they aren't necessarily able to understand it, and they aren't able to speak it. So it's a very frustrating, very, very frustrating position to be in for a patient. So I mentioned expressive aphasia. We also have receptive aphasia. This is where patients have difficulty understanding. So we might test it by asking them some simple yes/no questions to see if they answer them correctly. We'll also ask them to follow simple directions like make a fist or touch your nose. And if they're unable to do that, that's receptive aphasia. There are a few very specific types of aphasia, such as Broca's and Wernicke's, but it isn't necessary to know the different types of aphasia to know that if a patient has aphasia of any kind, then we need to look at what's their best modality. So we talked about those different modalities. Is it verbal? Is it writing? Is it reading? Or do we need to find an advocate for that patient because they're not going to be able to communicate on their own? The second one is apraxia, which sometimes aphasics also have apraxia. So with apraxia, patients now have difficulty forming the words. So they might substitute words or letters within the words, so they have difficulty saying the word correctly. And they actually sort of, grasp and grope trying to formulate the words. So with patients have severe aphasia and severe apraxia, they're really unable to communicate. At that point, we look for alternative methods of communication if they're able to utilize them. We also have neurological deficits. So neurological deficits are generally defined by memory, visual spatial difficulties, attention, delayed memory, and verbal reasoning. So we test for those. Any patient that has a stroke, we look at all the different neurological areas, and we might give them a screener like the SLUMS or the MoCA, and then we might do a bit more in depth like the RBAND so that we can really pinpoint what exactly they're having the most difficulty with. So oftentimes after strokes, patients will exhibit deficits with memory, attention, and verbal reasoning, and also those visual spatial deficits like the left neglect. So all of those are important to consider. Okay, we also have specific memory loss. So not all memory loss is defined specifically as dementia or Alzheimer's. So it's just important to remember that sometimes patients just have mild memory loss. I think we all have a relative that has some memory deficits and tells us the same stories over and over again. Doesn't necessarily mean that they have dementia or Alzheimer's. Those are very specific diagnoses based on a variety of tests that neurologists will give. But patients often have memory loss, so it's very common with age. And important to consider when we're sharing health information with patients. I had a patient not too long ago who was very frustrated because the physical therapist was giving her a lot of information at the same time. And she said it was just like too much for her to remember all at once. And so at the same time, the physical therapist was saying, she has a lot of difficulty retaining. She can't remember the slide board process. And so what we did is we broke it down into small bits. And we wrote it down on a piece of paper. So we wrote out, these are the steps to use a slide board. And the patient had really good cognitive skills. I had given her cognitive tests. She'd scored within functional limits. She just had some mild memory loss and she knew it was too much for her. So once we made that visual aid for her, then she was able to participate in the task without any difficulty at all. Another communication deficit is that of dementia and Alzheimer's. This is something we have to kind of tread lightly on. Sometimes patients are frustrated by being labeled as dementia or having Alzheimer's. I try to tell them that it just gives us the best picture of how we can assist them. So moving forward, we know that memory is going to be a problem. So we want to make sure that we do everything we can to assist you. So even though they have some negative connotations, I think it's important to educate people on these are just simply things that help us help you the most. And then I already sort of touched on the visual perceptual deficits. So the left neglect, or maybe some true visual deficits caused by glaucoma, cataracts and glaucoma. Or we sometimes also have patients that have lost their vision because of diabetic related issues. Okay, so now let's talk about some of the barriers to consuming that health literature. So aphasics, as I mentioned already, have barriers because they are having difficulty with understanding the words that we are giving them. They also have difficulty communicating. And sometimes we can offer things like a communication board where we have pictures that patients can choose from. Unfortunately, aphasia tends to cross over modalities. So if a patient is unable to say the word chair, they're also going to have difficulty choosing a chair from a picture. So we have to test both. So we have to show them a picture of a chair. Then we have to put a picture of a chair in a field of 3 and see if they can point to the chair. When we're creating those communication boards, we have to be aware of the fact that patients may or may not be able to utilize them because the aphasia, unfortunately, crosses all modalities. So it crosses speech, understanding, writing, and reading. For apraxics, most of them, if they are truly just apraxic, where they just have difficulty formulating the words, they will probably be able to consume that health literature quite well. However, we want to make sure that we test their other neurological areas so that they don't have any memory or attention deficits that would also impair their ability to consume that health literature. When it comes to neurological deficits, obviously memory is a huge barrier when it comes to consuming health literature. I can't tell you how often in our care conferences here, we talk about safety and patient safety and things that patients need to know in order to go home safely. And the number one deficit is cognition because they simply can't retain the safety protocols. So we might tell them every day, you know, you need to when you stand up, you have to use a walker to get to the bathroom, but they don't remember that they need to use their walker. So therefore it's a daily reminder. So now we have to think of ways that we can remind them in other ways, like signs and things like that. The attention often leads to, attention deficits leads to impulsivity. So if patients are having difficulty really looking and watching for what we are asking them to because they're distracted, they kind of have that squirrel mentality, then they become impulsive because they're not necessarily tuned in to what they should be and they're thinking about something else. So we touched a bit on memory loss already. So general memory loss can cause barriers because we're just not retaining the information. And dementia and Alzheimer's can complicate that a little bit because now not only are they not retaining the information, but they also might have difficulty comprehending the information. So if we have patients who have a diagnosis of dementia or Alzheimer's, we need to think of very simple ways to present the information to them in ways that they might be able to retain it. For our patients with visual or perceptual deficits, now we need to be very conscious of the written word and ways that we're presenting it. Are we making it in big print? Are we making sure that they have that guideline so that they're attending all the way to the left and not missing important information? Do they have glasses that they can use? If they are also having some visual deficits, then we want to make sure that we have information that is read to them so that it isn't something that they have to read themselves. So those are some of our biggest barriers to consuming health literature for these variety of communication deficits. Unfortunately, all of these communication deficits are something that patients often have to live with for the rest of their lives. So we do see patients who, after a stroke, have aphasia, then they do recover and they only maybe have mild aphasia or no aphasia at all. But unfortunately, when they have severe aphasia, it's usually for life. Same with apraxia. Apraxia is very difficult to overcome. So that's something that's long-term. Neurological deficits, we do see a bit more regeneration after a stroke when it comes to neurological deficits, unless now it's progressed to something like vascular dementia, which is the dementia that's caused most often by a stroke. Memory loss is progressive, so that is something that we can't make better. Instead, we're looking at compensation strategies. And the same with dementia and Alzheimer's. We can't reverse the course of either. We can try to slow the progression, But again, we're looking more at compensation strategies rather than, fixing it. And visual perceptual deficits sometimes get better, and sometimes now we're looking at long-time fixes to see how can we compensate for these visual deficits moving forward. Okay, so let's look now at some steps to overcome the barriers and improve health literacy in our patients. So it's good to know and understand the different communication barriers that patients face, but it's also good to have some tricks to say, hey, what can we do to make it better for the patients that we have right now? So one of the first is to assess health literacy. And there are, of course, a variety of different ways to assess health literacy. The Center for Medicaid Services actually requires that in the IRF setting, we assess health literacy at a patient's intake and also at their discharge. And so there are oftentimes in the medical record and the intake that nurses do, there's a simple questionnaire that they ask, and that assesses basic health literacy. We can also use screeners, such as the SAL-E and the SAL-S. These are quick screeners that we can use to assess patients' literacy. When you're assessing health literacy, it's important to understand the communication deficits that a patient has. So, for example, if they have aphasia, we really can't give them a true health literacy test because they have aphasia, so they're not necessarily understanding the words that we're giving them. It doesn't mean that they didn't have health literacy prior to the stroke and the advent of aphasia, but it's not fair to assess them with the current deficits that they have. So we need to be careful when we are assessing health literacy. This is also a time that we might bring family members in so that we can ask them, how well did your husband understand health information prior to the stroke? And that gives us a good read on how well they would do without those communication deficits. But ultimately, we have to remember that if they do have communication deficits, that we need to work around those and not just pretend that they're not there. Okay, so once we've assessed the patient's health literacy, now we want to share some information with the patient. We want to provide them some literature on, say, controlling their blood sugar or, avoiding high blood pressure. The best thing that we can do at that time when we're giving that information is to avoid jargon and slow down. So oftentimes we're in a hurry in healthcare. It's not common for us to have very much time to spend. But we need to be understanding of the fact that these patients have communication deficits, so we can't give them the information quickly. We're going to need to give it to them and give them time to consume the information, and we're probably going to have to give it to them more than once. So we want to avoid jargon. We want to speak in terms that they understand, and then we want to slow down. One of my favorite things, and I share this with all of the student interns that I have here at the hospital, is a study that was done called Commit to Sit. And some of you may be familiar with it. But with Commit to Sit, they did a study and they found that if you walk into a patient's room and sit down and then speak to them, they perceive that you spent twice as much time with them than if you stand up. And it's such a simple thing and it's so easy to do. And I will make a point to go find a chair, even if a patient doesn't have an extra chair in their room, just so that I can sit down and not hover. Because generally when you come in and you sit down and you make yourself comfortable, that indicates to the patient, I have time for you and I'm going to spend time with you and make sure that you understand what I'm saying. Those of you that work in hospital settings have probably very often seen doctors that breeze in, talk real quick to the patients, and then breeze out. And they're busy, and I understand that that's sometimes all that they have time for. But they don't necessarily take the time to make sure that patients really understand what we're trying to communicate to them. So we can walk in, and we can sit down and we can spend more time with the patient. And it also really empowers the patient. So it makes them feel like they are equal. And ultimately, that's really important because we don't want patients necessarily to feel like they don't have the right to ask us questions for clarification or that they're taking up our time. one of the best things we can do is to really make patients feel important. And that gives them the autonomy to ask for clarification and ask for questions when they have difficulty understanding us. Okay, our third recommendation is to use something to test the informed consent and educational materials to make sure that is at the reading level that patients can understand. So this is something that I don't know if I remember to mention, but this acute rehab hospital here just opened on August 23rd. We were a joint venture with another local hospital. So I came from that hospital to this facility, and we're still building our program. And one of the things that I'm working on is making sure that the educational materials that we're providing to patients fit their educational level. So one thing that you can use is a literacy level assessment. So on Microsoft Word, if you use Microsoft Word to create any of your materials, you can use the Flesch-Kincaid readability test. So you just highlight what you have created, and then you can use the meta-analysis, and it will tell you what the Flesch-Kincaid literacy level is. And 90 to 100 is considered 5th grade level, and 60 to 70 is considered 8th and 9th grade level. Also, because it's new and kind of fun, I played around a little bit with ChatGPT. So for those of you not familiar, I don't know how you couldn't be. It's like OpenAI is all anyone's talking about right now. ChatGPT is OpenAI, and it allows you to ask it questions and give very specific parameters, and then it gives you a nice piece of writing. So I'm just going to demonstrate that really quick. Let me make sure I'm clicked on here. Okay, so what I did was I asked ChatGPT to give me an explanation of aspiration pneumonia at a 4th grade reading level. And so as you see, it's using words that a 4th grader would understand. So aspiration pneumonia is a type of lung infection that happens when someone accidentally inhales food, drink, or vomit into their lungs instead of swallowing it down into their stomach. And so it's specifically using words that would be considered to be at the 4th grade reading level. So I think that's really cool. I did the same thing and asked it to put it at the 10th grade reading level, because a lot of our patients have completed high school, but they didn't go on to college. So, we want to use terminology that they understand, but patients also don't really like it if they feel like we're like talking down to them. So this is a cool way to bring it to their level. So here now you can read what it's saying at the 10th grade level. So aspiration pneumonia is a type of lung infection that happens when you inhale food, liquid, or other materials into your lungs instead of swallowing them down into your stomach. And it's a bit more specific. It says this can happen if you have problems with swallowing, such as after a stroke or with certain medical conditions. So we upped the terminology just a little bit. It uses words like irritate and weakened immune system. So it's using a bit more higher vocabulary. And then I asked it also to explain aspiration pneumonia at a college reading level. And now it's using words like infection, and saying foreign material can irritate and damage the delicate tissues of your lungs, leading to inflammation and infection. I also just had a little bit of fun with having explanation for PEG tube placement, because this is something that we spend a lot of time educating patients on. The other side of my job, I should have specified, as a speech therapist in a hospital, the other side of my job is swallowing. So that's why I spend more time explaining swallowing things to patients than I do like communication deficits. But I asked it to give me an explanation of a PEG tube placement at a 5th grade reading level. So I think that there is some ability for ChatGPT to be used if you are creating new materials for your facility and you want to at least get some guidance as far as what is considered to be an appropriate reading level. So at the 5th grade reading level here, it talks about, explains what a PEG tube is, a small flexible tube that's placed into a person's stomach through their belly. So always, of course, with any sort of AI, you want to check for accuracy. So if you do create some materials using ChatGPT, make sure that you read it carefully, that it's not giving any inaccurate information, because it is artificial intelligence, it's not human intelligence. But I think it can be a really good guidance, because it will give you information at the reading level that that patients will be able to understand. Okay, let me bring my PowerPoint back. Oops. Okay. So those are a couple great ways to create reading materials that are at an appropriate reading level. So Microsoft Word is good. I would assume that Google probably has something similar to test literacy level. I didn't play around with it. I was able to very easily find how to do it on Microsoft Word. And then the ChatGPT is another option, especially if you're generating completely new materials. It kind of takes some of the work out for you if you let the artificial intelligence create it for you. One more thing too, as far as testing informed consent and educational materials, is to do so via the teach back method. So if you're unsure if patients are understanding what you're saying, it's really easy to then ask them, okay, so I just went over aspiration pneumonia with you. Tell me what aspiration pneumonia is in your own words. And then patients can verbalize what it is that you just explained to them, and it will give you a good indication of whether they understood or not. Now, of course, this only works if patients don't have aphasia or apraxia, but if we're working with patients who have memory or attention or verbal reasoning deficits, we can get a good notion as to whether they understood us. Okay, next we have using alternative methods as needed. Sorry, I was seeing if someone had a question, but I don't think so. Okay, we're good. So using alternative methods. So for our patients that are having severe communication deficits via aphasia or apraxia, we can use alternative methods. So I touched briefly on communication boards. Not all communication boards are made equal. So there are some pre-made ones that you can find online. LinguaSystems is one that makes free ones. I often recommend making your own communication boards. So what I like to do is find out what it is that a patient is interested in saying. So they might only be at the level where they can say yes and no. And so we might do a communication board for them, and we'll just say yes and no. Or they might only want to choose foods. And so then I will make a communication board that has just the food so that they can choose their menu. We do have to be careful though, because we have to test how well they're able to choose things out of a field of 2, a field of 3, 4, 5, and 6. So when we are using alternative methods, this is where I would put my plug in for you to contact your speech therapist, because oftentimes our wonderful nursing staff will provide a communication board that maybe they had from a previous patient, and they will give it to a patient. But then the patient is unable to use it because there's too many pictures and they can't identify all of those pictures. So your speech therapist, your speech language pathologist will be able to test communication boards to see if it's something that a patient can use. If their aphasia crosses all modalities, then a communication board might not be the best option. Another thing to try would be a whiteboard. So we might use a whiteboard and see if the patient is able to write or draw what it is that they are wanting to say to indicate understanding. And so these alternative methods can be used as needed. If a patient has visual deficits, we want to make sure that we provide everything verbally. Alternatively, if they have hearing deficits, that's when we might want to provide things in the written form. When we're looking at and trying to find alternative methods, this is, again, when you want to contact your speech therapist, because that's something that they're trained to do. It's something that they are ready and willing to do, and would be very, very happy to be consulted. And that brings us to our fifth step, which is reducing shame. And I really, really, really want to emphasize this, because when patients have difficulty understanding, it comes with a bit of shame. And we want patients to know that their communication deficits are not due to anything that they should be ashamed of, that we are working with them where they're at right now because they've had a major life event that has changed a lot for them. And so our efforts to communicate with them and to provide health literacy at their level is important to us. We want to make sure that they understand us. And so we want to make sure that we are empowering patients to ask questions and to tell us when they don't understand something, and to ask for repetition when needed, and to tell us, what works best for them as far as communication. So generally, anytime that we just provide patients with as much dignity as possible, then we're automatically reducing shame and making their lives better by improving their health literacy, which improves patient safety and outcomes and experience and all of those things. So yes, thank you. I just saw the chat box. I'm sorry, but the ChatGPT is free. There is a free version. There's a paid version, but I have not tried it. I've only messed around with the free version, but it does have limitations. Yes, I do agree with Brian. And as I mentioned, you do have to make sure that you review it yourself, because it's artificial intelligence. So you can ask it for guidance, and that's what I've used it for in the past. If I just was like struggling a little bit on the best way to explain something to someone, then I'll pop it in there and see what words they used, and it can be a guidance for you. But it isn't perfect. So you do have to be careful and definitely cross-check everything that you do. So, and thank you for those that provided other good health literacy measurements as well. Yeah, perfect. Okay, so that brings us to our next steps. So where do we go from here? So let's say we want to implement some of these steps to improve health literacy for our patients with communication barriers. The first step, it might be to educate your staff. This is something that here at our hospital we are doing on a regular basis. So I recognize that I am someone that works with someone with communication deficits every day, but not everyone does. So we are constantly educating our nursing staff. We're actually also constantly educating our physicians and our techs and everyone who interacts with the patient on a daily basis. So continuing education is needed. We can continue to assess and evaluate the effectiveness of measures taken. So if we start to use health literacy and we measure at what reading level it's at and we give it to patients, we can ask them, hey, how did you feel about the information that we gave you regarding the controlling of your blood sugar? Did you understand that? Was the words those that was easy for you to understand? And just get a read from the patients on how they're doing with that information. One of the things that I hope that you'll take home from this presentation is to make small changes. So Rome wasn't built in a day, so maybe just implement a couple things and start from there and see how they're going, and then add to that as things are going well, or revise as needed. So constantly, evaluating and making small changes is really important. And the last step is just to provide reassurance. We're not going to get it right with every patient on the first try every time. And there's going to be patients that are going to be more difficult than others because of the severity of their communication disorders. Sometimes then we need to bring in family to help, or advocates to help them. But we want to reassure everyone that we are trying and we are doing the best that we can to bring the health literacy to the level of the patient. It gives them such wonderful autonomy, really makes them have a better experience in the healthcare setting, and then it overall improves their experience and the safety when they go home. Okay, so just a couple references that I utilized for this presentation. So if anyone wants, I can copy and paste those into the chat box. And that's it. So I think that now I have time for some questions. I see a Q&A up here. And so I'm just going to click on that to see what happens. Okay. Heidi says, my understanding is that Alzheimer's and dementia are two very different and separate diagnoses. Is that correct? I see you combine the two on your slide. Yes, they are very two different diagnoses. And again, they are diagnosed by a neurologist. So when we are working with patients who have dementia or Alzheimer's, we are looking for that diagnosis and diagnosis code in their history and physical. And so we would never suggest to a patient that or to a patient or their family that they have dementia unless it's already been diagnosed. However, if we are noticing dementia-like symptoms, we will be sure to tell the physician that, and then sometimes we will have an open conversation with the family and say, we recommend that you follow up with a neurologist because the neurologist can make the diagnosis of dementia or Alzheimer's. Good, and we got the cost question. Okay. Okay, someone said this really feels like it's reinforcing the idea that a patient's low literacy is their personal deficit and that a provider never has any of their own barriers to communicating clearly to their patients. What provider characteristics are deficits that lead to not meeting the patient's needs regardless of their health literacy level? I mean, that's a great question. It was not the focus of this presentation. The presentation here was focused on patients who have communication barriers. I think that trying to address providers' communication deficits would be like its own presentation. I can tell you that from my experience of working in the hospital setting that oftentimes physicians English might be their second language, so there can be some language barriers. We didn't really touch even on language barriers because I don't consider that to be a communication deficit. I think that that's a completely different topic. Today's focus was communication barriers because of things like strokes and that I'm a speech therapist. So as far as providers providing materials that are appropriate to patients, I think that some of the things that we touched on today, like checking the health literacy level of the materials that we're providing, and also just checking for feedback from the patients. So using things like Commit to Sit and the Teach Back method would be really great ways to make sure that when we're communicating to patients, they understand. It's sort of a big, I would say, those of us that work in communication, because I'm a speech therapist, we have a pretty good read on if patients are understanding us or if they're tuning out. But again, that training of staff is one thing that we can do too, so that people are aware that when they're talking to patients, the patients might not understand them. Increasing that awareness can be really empowering as well. What evidence resources can you share that reflect the benefit of educating and re-educating dementia and Alzheimer's patients? Michelle, it's a good question. I don't have any resources right here to give you. What I do know is that from our years of working in healthcare as speech therapists is we do our best to educate and re-educate patients. But more so, I think with patients with dementia and Alzheimer's, you're going to have to look for the compensation strategies, which I think I mentioned. So now we're saying, what can we do to compensate for the memory deficits that these patients are living with? Are we going to create something like a memory book? Or are we going to put posters on the wall so that patients can be reminded of the day of the week, where they are on a regular basis? And then it's also important to bring in an advocate for them, because we know that if it's advanced dementia or advanced Alzheimer's, that's when they're going to have more difficulty retaining anything. So yeah, and as far as resources, I would say I'm a big proponent of memory books. I think that they can be really helpful for patients. It's kind of out of the scope of the health literacy, but you can, throw some health literacy information in there for them as well. So good. Okay, any other questions? Otherwise, I want to make sure that I thank all of you for coming to my presentation. I know that there is a question and answer also when the presentation is over. So if you think of questions, I think that you can pop them in the conference harvester. And then I'll be sure to check those and answer any questions that I can. So thank you all for coming.